Hello, my name is Caroline Ballerstedt, and I am a nursing student at the Community College of Rhode Island. And today I will be speaking with you about what it means to be a nurse in the era of institutional racism and mass incarceration. We'll begin by examining the social determinants to health and what that may mean for our patient populations. Social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. Social determinants of health have a major impact on people's health, well-being, and quality of life. Examples of the social determinants of health include safe housing, transportation and neighborhoods, education, job opportunities and income, access to nutritious foods and physical activity opportunities, pollution in the air and water, language and literacy skills. And of course, what we'll be talking about today would be the major contributing factor to the health of a community, which would be racism and discrimination and the violence that accompanies it. I'm going to focus today more on institutional racism versus individual racism, like the prejudices of an individual person. So the term institutional racism describes societal patterns and structures that impose oppressive or otherwise negative conditions on an identifiable group on the basis of race or ethnicity. Oppressions may come from business, the government, the healthcare system, the schools, the court, among any other institutions. So what are the effects of institutional racism on health? What would we as nurses see in our patients, and how could we contribute that either in part or in whole to racism? The data shows that racial and ethnic minorities throughout the United States experience higher rates of illness and death across a wide range of health conditions, including diabetes, hypertension, obesity, asthma, and heart disease compared to their white counterparts. Additionally, the life expectancy of non-Hispanic Black Americans is 4 years lower than that of white Americans. In the next few slides, I will review some of the major health disparities among racialized populations. These include cardiovascular disease and the accompanying diseases of obesity, diabetes, and hypertension, maternal mortality, pain treatment, as well as COVID-19. Heart disease is the leading cause of death in the United States, and risks of heart disease death differ by race and ethnicity. Non-Hispanic Black persons are more than twice as likely as non-Hispanic Asian or Pacific Islander persons to die of heart disease. Unfortunately, many of the risk factors that predispose patients to developing heart disease and heart failure are more common in Black patients. For example, Black patients are more likely to have high blood pressure, and it is often more advanced and diagnosed at an earlier age than in other groups. Because of the higher rates of other cardiovascular risk factors such as diabetes, smoking, obesity, physical inactivity, and high blood pressure, Black patients endure a greater burden of heart disease and heart failure. However, it is crucial to mention that Black people are also more likely to suffer from health inequities as the result of these social determinants of health that I mentioned earlier. Both structural and social inequities, which can cause increased stress and distress in the medical system, a lack of nutritious food options such as living in a food desert, and poor access to medical care have a direct link to the development of heart disease and heart failure. As sobering as this news is, many of these risk factors are modifiable. So when the risks are properly addressed and treated, then we have the ability to reverse this trend. In terms of hypertension, a study found that there is a substantially higher hypertension rate for Asians and Hispanics compared to non-Hispanic whites. This prevalence was also higher for South Asian versus Eastern or Southeast Asian adults. Hypertension rates were the highest for Dominicans compared to Puerto Ricans and Central and South Americans. Causes of the ethnic and racial inequalities are multifactorial, but substandard insurance coverage and poor access to healthcare are primary determinants of these disparities that are associated with poor hypertension control. In terms of obesity, minority groups share a disproportionate risk for obesity and obesity-related diseases. Hispanics and Blacks have significantly higher odds of obesity and its related diseases. Although the exact cause of these differences in obesity are not all known, they likely reflect differences in social and economic advantages related to race or ethnicity. This concept aligns with other more general statements about health disparities, explaining that disparities are closely linked with social, economic, and/or environmental disadvantage, and shows the effect where groups of people have systemically experienced greater social and/or economic obstacles to health based on their racial or ethnic group. Moving on to maternal and infant mortality and morbidity. Approximately 700 women die in the United States each year as a result of pregnancy or its complications. Black and Native women have pregnancy-related mortality rates that are over 3 and 2 times higher, respectively, compared to the rate for white women. Further, other research also shows that Black and Hispanic women have significantly higher risk for severe maternal morbidity, such as preeclampsia, which is significantly more common than maternal death. Reflecting these increased risk factors, infants born to women of color are at higher risk for mortality compared to those born to white women. The factors driving disparities in maternal and infant health are complex. They include differences in health insurance coverage and access to care. However, broader social and economic factors and structural and systemic racism and discrimination also play a major role in shaping health and disparities in health. In maternal and infant health especially, the intersection of race, gender, poverty, and other social factors shapes individual experiences and outcomes. An often overlooked issue in racial health disparities is pain management. Racial and ethnic minorities consistently receive less adequate treatment for acute and chronic pain than non-Hispanic whites, even after controlling for age, gender, and pain intensity. Pain intensity underreporting appears to be a major contribution of minority individuals to pain management disparities. The major contribution by physicians and nurses to such disparities appears to reflect a limited awareness of their own cultural beliefs, stereotypes regarding pain, minority individuals, and the use of narcotic analgesics. Half of white medical trainees believe such myths as Black people have thicker skin or less sensitive nerve endings than white people, according to a study published in the Proceedings of National Academics of Science in 2016. That wasn't very long ago, 2016. Assessments and treating of pain are complicated. People process pain differently, and they can express it in ways that are silent or loud, articulate or guttural, demonstrative or reserved. In addition, pain assessment is inherently subjective. Additionally, in cases of medical ambiguity, as when pain isn't caused by an obvious physical symptom, such as traumatic injury, providers rely more heavily on their own judgment, which can be influenced by personal perceptions and biases. In fact, in this meta-analysis, the greatest racial disparity in pain treatment was for conditions like backache, migraine, and abdominal pain. Racial and ethnic disparities in pain treatment are not intentional. Instead, inequities are the product of complex influences, including implicit biases that providers don't even know that they have. The COVID-19 pandemic and its disproportionate impact among racial and ethnic minority populations is another stark example of these enduring health disparities. Over the course of the COVID-19 pandemic, analysis of federal, state, and local data have shown that people of color experienced a disproportionate burden of the cases and deaths. They have shown particularly large disparities in cases and deaths for Black and American Indian and Alaskan Native peoples, and in cases among Hispanic people compared to their white counterparts. While disparities in cases and death have narrowed and widened over time for some groups due to a variety of factors, the underlying structural inequities in health and healthcare and social and economic factors that place people of color at risk at the onset of the pandemic remain. As such, they may remain at increased risk as the pandemic continues to evolve and for future health threats. I would like to begin this section on over-policing and police brutality with a quote from Dr. Aletha Maybank. "People are dying. That's our business, whether they are dying through a slow violence such as structural racism or COVID-19, or direct violence like police brutality. If death and injury are outcomes of any disease, we in the health space have a responsibility to understand why and to act." The role law enforcement has come to play in community health response is dangerous for communities of color. Police encounters with Black Americans are more likely to result in injury, violence, and death than encounters with their white counterparts. The health harm of historical trauma and racism are compounded by police killings, which are associated with poor birth outcomes, psychological distress, depression, and post-traumatic stress among Black communities. These long-term negative health effects are the direct result of racism-related toxic stress and exposure to the harshest, most frequent forms of police violence. It is clear that police officers are not well suited as healthcare responders and that the safety they promote is not distributed fairly to Black Americans. It is imperative that we ask ourselves, safety for whom? When law enforcement officers pledge to protect and serve, we must ask ourselves, who are they protecting? Who are they serving? You can't discuss racial health disparities without considering the impact of the criminal justice system. Over the past 40 years, the United States has taken part in an experiment in mass incarceration. Incarceration rates up until the mid-1970s were relatively stable, after which they began to increase exponentially due to an increase in the demand for more punitive versus rehabilitative criminal justice policies. Nursing in a world with mass incarceration should affect how nurses provide their care. Nurses need to become more aware of the issues of incarceration and the associated health disparities, research health causes and consequences, consider correctional nursing as a career, advocate for policies that benefit the incarcerated, and partner with institutions to ensure strong referral and set up incarcerated individuals for success upon re-entry into society. Incarcerated people tend to have higher rates of chronic illness, infectious disease, mental illness, substance abuse tendencies, and other issues. People who live in correctional settings are at the highest risk for exposure to COVID-19. In fact, a majority of the largest single-site outbreaks since the beginning of the pandemic have been in jails and prisons. These issues are critical for nurses to address in order to help these patients heal. Incarceration is an issue that is beginning to emerge at the forefront of the American political spectrum. With a high rate of incarceration in the United States, it is essential that inmates receive adequate and high-quality care as any other patient outside of the detention center walls would receive. Nursing in a country where such a massive incarceration system is present should affect how nurses provide their care. They need to be conscious and proactive when combating the system's negative effects during their provision of care. The experience of incarceration and the conditions of prisons interfere with a patient's emotional and physical safety, and institutional policies often place security concerns over the basic norms of compassionate care. Regardless of whether a nurse is employed at a correctional facility, it is likely that they will have incarcerated or formerly incarcerated individuals under their care. It is imperative that nurses acknowledge the physical and spiritual trauma that accompanies incarceration and let that inform their care to these individuals. So after all of this, you may be asking yourself, what is the ethical responsibility of the nurse? What can we do as individuals and what can we do as a group to care for our patients in a more equitable way? The aims of nursing, to heal, to support, to prevent harm, directly conflict with the operations and intentions of racism, policing, and prisons. Racism in nursing prevents the profession from addressing social and political determinants of health, including harm to health caused by policing and prisons. Nurses are not liable for injustice, but we are responsible. We are better equipped as a group to bring about social justice than as individuals. It is not enough to diversify workplaces and offer health information in many languages. Seeing, acknowledging, and understanding the impacts of race and racism in our patients is only the beginning. There are 3.8 million registered nurses in the United States. This is a powerful political lobby to demand not only an end to human rights violations by police and prisons, but also an end to policing and prisons as state institutions of oppression, and the alternate investment in safe, equitable, health-promoting services.